Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Welcome, everyone, into this week's episode number 483 of A Tale of Two Hygienists podcast. I'm your host, Andrew Johnston, and thank you so much for being with us today. Today's episode is going to be a little bit different. I know normally, Wednesday episodes are going to have a guest, but I was asked a question that I just felt like I wanted to answer, and I was going to normally do it on a tip episode, but then, man, tip episodes, they're only 7 to 10 minutes, or at least they're supposed to be, and I always go 15 minutes, and I just like, you know what, this one, I just have a lot to say about. There's not a lot of things where I'm like, you know what, let me get on the mic and let me just handle this part. But this is one of those things I feel very strongly about. And it's interesting because whether you're in private practice or whether you are in like a DSO setting or a corporate setting, this applies to you kind of universally. And the theme about this is there's kind of like two simultaneous themes. One is, I'll talk about it in a minute, but there's this movement going on right now about like our autonomy and our ability to be recognized as the professionals that we are. And there's within that two things that are happening. One, there we are being attacked by the outside of our dental hygiene profession. People are coming at us saying, hey, you're not qualified, you're not smart enough, you're not good enough, you only do this, you only do that. And those same people that are saying that are the ones that are delegating only those couple of tasks to us, or only allowing us to do these couple of tasks. They're limiting what we do. But then what I think has happened over the last at least decade, probably more. I don't have a long time in this profession, only 15 years, and the thing about it is, I feel like we started like listening to them tell us all of this stuff, and we just started kind of going along with it. And we just have to kind of take back the reins, take back control of our profession, and not be those ones that are complacent. I know it's so easy to go in and be that clock in, clock out. I'm not really looking to get better. I think I know what my skill set is. But part of this episode is saying, hey, there's actually maybe one more thing that you could be doing. Now, separate from that kind of issue, the other thing that I want to talk about, and it's in the title of this episode, it's about assessments versus judgments. And gosh, it's an interesting thing because I think assessments are when you put on your scientific hat, and judgments are kind of when you put on your I'm just a human being hat. And there's definitely a delineation that needs to happen in our profession where we stop doing the judgment calls and we start doing assessments, and then using those assessments to have evidence-based diagnoses and treatment recommendations and prescriptions and outcomes. So let's get into this. So I wanted to talk about kind of chart reviews or chart prep, and it doesn't really kind of matter how you say that. I know that chart reviews sometimes are more when maybe a boss or something is reviewing the charts that you've already done. But what I guess I'm talking about is more of like you reviewing your patient charts either for the next day or the morning before your patient arrives. So as I was thinking about this, I kind of felt a little bit guilty because it's like, when are we supposed to be doing this? And I think if you work in a corporate setting, almost all of them will say you have to do this the night before. You have route slips that you need to kind of just, maybe you're documenting some stuff on your route slips, making notes for yourself. You can put stuff into the actual appointment itself. You can attach treatment and things like that. And all that's true. And that should happen. And I think that most corporate offices would say that. But I also think that there are people that do it in the morning of. And if you've done a long day of work and you're just done, I don't mind as long as you're not clocking in too early and, working off the clock and doing those types of things, that you arrive early enough to be able to review those patients' charts and do that same exact task without being late for the morning huddle or putting yourself behind with your first patients and things like that. And I think about my last full-time employment when I was doing this, I got to the point, and this is maybe where you're at in your career kind of thing. I got to the point where I'm looking at these charts. I'm like, I can quickly analyze within just a couple of minutes the things that need to happen for the next patient. And it doesn't matter if I'm the one that saw them last time or someone else saw them last time. I think we get to a point, and if you have a system in place, you'll get to that point too really quickly. Now, going back to the judgments thing, I think one of the things as we're doing our chart preps, we start thinking about our patients. And sometimes, and I'm definitely guilty of this, I think about the last interaction that I had with that patient. I remember very specifically a handful of patients where I'm like, I did not have a great last interaction with them. And it kind of sours me to the appointment. And I understand that a lot of people don't do chart reviews because they allow these types of obstacles or hurdles to be in their way, whether it's going to be, I don't want to think about those last interactions because some of them are going to be negative, or I feel overwhelmed by the amount of work I have to do the next day or later on that day. And that's going to kind of put me in a kind of a sour mood for the rest of the day or for their appointment that's coming up. And I don't think there's anything wrong with having some of those feelings as just kind of reaction type feelings. It's just what you do with those feelings, I think, is really important. We're human after all. Like, we're not freaking robots. And having said that, I think what I'd like to do for the rest of this episode, though, is I am going to just like set aside the judgment part and just kind of focus on the assessments. And then as a side note, I think it's also just in general super appropriate to adopt a kind of a personality that's, I don't know how else to say it, but like, in quotes, like strictly clinical, having that perspective with your patients. Not to say that you can't talk about like dogs and vacations and family and things like that, but I think that part of the appointment needs to be super short. And I think that, and this is just an Andrew's opinion kind of a thing, I don't think that there's room in our chart notes for the name of someone's dog. Doesn't mean that they can't be somewhere in their chart, but not in our chart notes, the things that we're reviewing today. And the reason I think this way is because you think about the last time you went to see your doctor. Generally, the way it's happened for me, at least, we've had like a physician's assistant or a nurse that would take us back, do all of the, pre-doctor discussion stuff, all the data collection, whatever, check my blood pressure, check my weight, ask me about different updates from my medical history, all of that. Ask me why I'm there if it's not already documented. And I'll say, okay, well, doctor will be in soon. Doctor comes in. They say, what's going on? We talk for a little bit, and then I'm on my way with whatever they recommend, right? Or whatever they prescribe. That doesn't happen in dentistry. In dentistry, for some reason, we're like, you know what? We have to be that peppy up, like we're this, that's going to offend a lot of people, but kind of like a cheerleader in some ways. We're the ones that are like, go, you can get your mouth healthy. We can do all these things. Oh, how is your family? Let's talk about them. Oh my gosh, they're in this grade already. Oh, the little Timmy is just growing up so big. It just was just yesterday when I saw him as a baby in the chair. I mean, that's never going to happen in a medical facility. Like, it just does not happen. And so we have to look at ourselves and say, hey, we're part of the healthcare team. And as long as we continue, and we are having these fights. If you look at Derek Sven, for example, is one of them. He's out in Virginia. He's the ADHA president-elect for the state. And he put out a really, really great video. And basically, it was a rally cry. It was an anthem of like, hey, enough is enough, man. We are going to go after our autonomy. We are going to go after, proving to these legislators that we are educated, that we are not dental assistants, that we have a huge gap between the two of us, just like there is a huge gap between dentists and hygienists. And hey, this is how we can kind of progress, and this is how we can all evolve together. There's still a place that's wonderful and awesome and necessary for dental assistants, and it's right here. And this is the necessary place for hygienists, but let us use our full scope that we're trained on and licensed for. And then, hey, here's the scope for dentists, and this is what they're trained on and licensed for. And we all have our roles to play. Simultaneously, we have bills that have been introduced that we just freaking lost. Like in Arizona, for instance, there was the bill that introduced dental assistant scaling. And you know what? We need to be fighting for these things, and we can't be fighting for those things as the peppy, happy, just smiley, bubbly, sweet person that never talks about people's oral health or their systemic health. We're not being the clinical educators that we are. We need to focus on the patient and their health outcomes. But I'm getting into the weeds. So we need to go back to chart reviews. So chart reviews. When should we be doing chart reviews? I think there isn't a really solid answer, and I think it's variable depending on your experience, as I said earlier. I used to look at the very beginning, I used to look at the charts every night before I left. So we had 10-hour days, and we'd have approximately 10 patients. Sometimes if we had scaling route planning, we'd have 9 patients or 8 patients or whatever. But generally, it's around 10. And so the night before, I would look through all the things that say, okay, who needs radiographs, who doesn't? Let's look at the medical dental history, see where we're at with that. What were some of the last procedures that were done? What does the perio chart look like? What kind of mess am I getting myself into? Is kind of unfortunately the mentality I thought at that time. And that's really important. So I think, at nighttime, the night before, the afternoon before, especially if you have a break between patients, then that's a good time to do it as well. But I think that if you're new to the patient base, the night before is still really helpful. If you're newer to the profession, I think the nighttime or the evening time or whatever, afternoon, I think that's the time to do all of those things. I think that's really helpful and beneficial. But as the years go on, as I was more comfortable with maybe the different cases that showed up, I wasn't so scared when there was a 4 quads of scaling and root planning put in my chair for 2 hours or whatever, and I was daunted. Oh my gosh, I can't do that. I was also better at kind of picking quickly the things I need. I could look at the extras real quick and just say, okay, this is the last time. This is what doctor always recommends. This is what we're at. And so for when that kind of stuff happens, I don't mind going in just a little bit earlier for the morning huddle than just doing it then, because I can catch up really quickly. It won't take much, probably more than 10 minutes for me to catch up with my whole entire day's schedule. I think also one thing I forgot to mention is, in order for the process to be really streamlined, for everything that you do to be quicker for the chart review, you have to be planning, scheduling, and attaching treatment to the next appointment while they're still in the chair. So if you know that their next visit will be, we'll say it's a prophy, it's going to be in 6 months. And at that appointment, they are due for x-rays, they're due for fluoride, they're due for an oral cancer screening, they're higher risk for oral cancer, and you've already had that conversation. Just go ahead and plan and attach all of that to that next appointment that you're scheduling. And if you do that consistently, when you're doing your chart review, you're just basically double checking yourself and be like, yep, I was right there. Oh, I forgot this one thing. It's so much easier to go through rather than just the chaos sometimes that doesn't have any treatment planned on that appointment. And I think also, not only does that step really help you, it helps the patient. So if they call ahead and they're asking, hey, what are we doing for that appointment? Sometimes the schedulers, whether they're treatment coordinators, whether they're just someone in the front office, sometimes we have offshore call centers. And even the doctors sometimes get asked, like when they're in for maybe like a limited exam, hey, doctor, what's my next thing? If all that treatment's not really attached, it takes everyone a minute to look through it. And the doctors probably could say, hey, this is what you're due for, because they're kind of in the same boat that we are. Assistants could probably do that also, easily looking through and say, this is what you're due for. But maybe sometimes the front desk doesn't always know. Maybe they're new, maybe they weren't trained. And so having all of this attached is super important. And so the next thing I want to talk about is kind of like the few topics of like, what are we actually reviewing? So the first thing I go through is medical alerts, the med list, and medical dental history. I'm constantly amazed by how little information that patients give us. It is ridiculous that they just put up these barriers and won't give us anything. But it also constantly surprises me how little that we pay attention to getting more comprehensive medical interview style, like situations, scenarios with them. It's not glamorous. Patients can be definitely prickly. It's not going to give us that same satisfaction of popping a piece of calculus off, watching all the bleeding, and then coming back to that spot later in the appointment and be like, oh, look, it's already starting to turn a little bit pink. But this is definitely a legal requirement. It is an ethical requirement. You have to do your best to collect this data each time. There is no way that you're going to understand how to comprehensively treat your patient unless you have all of the information. There's just no way. And there are going to be times, definitely in your career, that if there's a medical reason that they're not responding to periotherapy, for example, especially in a way that in 9 times out of 10, they would respond a certain way. If you're missing it, if you're saying, hey, well, hands up, like I'm, shoulders shrugged, I'm so sorry, that's on you. Your body's just not healing. And you're not looking at everything, that's on you. You are not doing your job as a dental hygienist. And I know that sounds kind of harsh and kind of sounds a little bit aggressive, but that's kind of what we're talking about. This, again, going back to this whole fight that we're doing. If we want someone, a dental assistant, to come in and mechanically scale someone's teeth, look, people can be trained to do that. They really, really honestly can. But if what we have that's different is our education and our background and our experience, right? We have all of this knowledge in our heads that we need to be able to have these medical dental history conversations, these med alerts conversations, these med list conversations. We have to be looking at our meds list. We have to make sure that what's reflected on the medical history part as far as ailments or diseases has a correlated drug on their meds list. And if it's not, then we have to ask the questions. Now, the great thing is with technology nowadays, we have a lot of databases that has the patient's medication in it. And that's amazing because we can just get the med list and we can see what their dosages are. We can see how often they're supposed to be doing it. And we confirm that they're actually taking them and we're done. But the opposite isn't always true. We don't always have a medical dental history in a place that's kind of like singular like that. So there's not usually, depending on where they go for their healthcare, there's not usually like a list of like, okay, here are the 5 drugs and their dosages. There's not like, here's their 5 ailments or diseases that they have. It's not that succinct. It's usually like a giant med history that you'd have to go through, then have to transfer that information to your med history. And that's just a little bit convoluted, a little bit difficult to kind of decipher. And so I think looking at the meds list and then going in that direction, I think is really easy, but we have to be doing these things. The next thing I always look at is, we call it the ledger. I think most people call it the ledger. Some people call it something else, but you look at the last items that were walked out on the ledger. This is going to give you a super quick indication of what hygiene procedures you're working with. So is this a perio maintenance because they just had SRP on the ledger that was walked out, or they just had a perio re-eval on the ledger that was walked out, or they just had a perio maintenance on the ledger that was walked out, or is this a prophy because the last appointment was a prophy? Now, this isn't the end all be all, because you could get in there and you could realize that, hey, the patient is presenting for a prophy because that's what is scheduled and that was the last thing that was on the ledger. But dang, according to this data, the perio chart, the radiographs, all of this stuff, this is actually a perio scenario, right? This is a perio patient in some regards. And so you'll get in there and you're expecting one thing, you're going to find something else. In these types of scenarios, and actually kind of just generally anyway, I'm not a not trusting person, but I do like to have as much information as possible, or all the information if at all possible. So I'll scroll back and I'll actually look at the last several entries for the last several appointments, because sometimes I don't know why we do this, whether it's going to be a doctor, whether it's going to be a hygienist, but if I'm not the person that has seen them for an extended period of time, they're kind of bouncing between people in the clinic. There's definitely an opportunity for a perio maintenance to come in and get billed out as a prophy, whether it's by accident, whether it's intentional, I just don't know. So I like to scroll back and look at the codes kind of along the way and see if there's anything that's out of place. Now, if the patient is a prophy, about 4 years ago, I'm finding something in the 4,000 codes, right? So that's your 4910, your 4341, 4342, even 4346. I'm looking, I'm like, there's something that's just out of place compared to prophy of what they're here for today. And I want to know why. Why did we switch them? And so then you have to be a little bit more of a detective. You'll look at anything that we might have prescribed that might have helped them get healthier. So perioprotect trays, whether they're using antibiotics, whether they're using some localized subgingival antibiotics or whatever they're using. What did we prescribe? How did they respond? And then lastly, I think on the ledger, we need to be looking for kind of an outstanding payment due. I don't like this one as much. It's very uncomfortable, but I think when we're thinking about like the teamwork part of what we do in the dental offices, we're the clinicians. We need to be focusing on clinical stuff. We're doing these chart reviews anyways. It's not that hard if you happen to notice something, and you should be looking for it. But if you happen to notice something, then you have that conversation with the front, whether it's going to be the manager, the treatment plan coordinator, whoever's going to be handling the money or checking that patient in. They should be made aware that there's a balance, because many offices, depending on the balance and kind of the rules of the office, many of them will have a policy in place where they have to collect that balance first before the patient is seen. I just was hearing on a podcast, I think it was yesterday, how there was a dentist that said, you know what? Actually, I was talking to a doctor in person. That's what happened. And he was saying, you know what? I have a bunch of friends who shifted their practice into collecting money before the services were rendered. And that took away all of the headache. Now, again, I know we're clinical. We stay in the clinical side of things as much as we can. However, this is still a business, and that is one thing that you can show to the business owner, whether it's going to be, the doctor that you work with, or maybe that, the doctor's boss, whoever, that, hey, I'm a team player. I'm looking out for everybody. This is where we're at. Kind of along those lines. And I'm just now, as I'm saying all this stuff, I realized I didn't actually make a bullet point for this to talk about. But when you're doing these reviews of past treatment and stuff like that, I didn't actually put a section in for outstanding treatment. So kind of like it's similar to an outstanding balance, outstanding treatment, it's even more on the clinical side. If they didn't do the treatment recommended for the hygiene side of things, then obviously that's in your court. But it's always nice to bird dog some things for the doctors. So if they're presenting and they still have, a crown or a filling or something that needs to be done, it's really, really important. Not only do you talk to the front and say, hey, maybe they can piggyback this and work this in, sometime during our appointment, or, let the doctor know at least, hey, one of the things I did with my doctors, I said, hey, I know you don't have an exam today, but do you mind popping in and seeing, Timmy again and saying, hey, don't forget about this filling. I need you to still get done. Because I've already told the patient about it too, but I think they also need to hear from the dentist And I think that way they'll be more likely to get the treatment that they need. The next thing that I always review is the most recent set of notes. So I go back not just to the last hygiene appointment, but the last few hygiene appointments to review the notes. If you have templates, this is a lot easier to look at and kind of summarize without having to be reading paragraphs and paragraphs of things. I like to focus on the home care instructions portion that were given, so I know what to ask right away. How are these very specific things I asked you to do last time going for you? What obstacles are you having? How can I help? Right? That's kind of how that part goes. I mentioned earlier that sometimes we use delivery of local antibiotic, and I look in those areas and say, okay, what areas were they? Okay, I need to pay attention to them. Did we get a perio referral? Was there a periodontist involved in all of this? What were their notes saying? Do I need to watch out or don't touch certain areas, et cetera, et cetera? A lot of times there's also recommended recall frequencies and the dates to see if they are on target or if they're overdue. So that's a really important thing for me. Recalls can be anything from like what we normally think of a recall, where it's just like, hey, this is our prophy appointment. This is going to be your annual. This is going to be your, para re-eval recall, para maintenance recall, whatever it is. But I also think that sometimes when we get out of sync, then that throws off our para recall schedule. So looking at the dates is really going to be important, and kind of reevaluating and resetting some of these dates, especially if it's a para maintenance situation. And so while I think it's really important to review the most recent notes, the notes sometimes can be a little bit subjective for me. I'm a guy that likes, hard evidence, hard data. Give me that information first. I love perio charts. I love x-rays. I like to form my own opinions based on what I'm seeing, and then kind of collaborating with, a second pair of eyes or a third pair of eyes as needed to make sure that we're getting the right treatment done. So I do actually read some of the subjective portions, kind of in that a lot of times there's like an open field in the bottom that has the notes that are there. But if in that field, I'm seeing, 4 paragraphs of, kind of what starts off as more like an opinion piece, I'll actually kind of skip over that. I don't really have time for all of that. You don't have time for that either. So really kind of stick with as much objective clinical assessments as you can. Try and glean quickly any pertinent information from the actual clinical notes. But take it with a grain of salt. Then radiographs. Radiographs are an interesting thing because you do definitely need to review them. And to be clear, there should be some sort of policy built into your office for every type of appointment that you have, whether it's going to be a new patient appointment, whether or some sort of a recall. If they're a perio patient, then these are the x-rays that I want on every recall. If they're a new patient, these are the x-rays I want. If they have pain or if they have a broken tooth or if they have whatever, these are the types of PAs I want. Not every dentist, however, has the leadership skills or even the organizational skills to get this implemented. And it doesn't make them bad at their job or any of that kind of stuff. It's not that, right? It's just that they just don't do it, or maybe they don't think about it, or maybe that's just not the way their brain is wired, and that's okay. So in these kind of cases where they don't have a system in place for what types of radiographs have to be attached to each appointment, maybe give them a little bit of a nudge, or maybe you can help be the person that creates this in your office, creating that outline. Because a lot of the problems that we have in our office is about communication, right? We say, all right, doctor, our patient's ready. Then the doctor comes in to do their check. And I say, you know what? I want a PA on this one. Well, dang, doc, if you would have told me that I need a PA on these types of situations or these scenarios, then I would have already taken that PA for you, and we would not have to be behind for the rest of the day because of the extra x-rays that you want, right? So I think that if they don't have it, maybe you can be that person that kind of gets it implemented. It really is serving you. It's definitely serving our patient, right? They got stuff to do too. They don't want to be in the chair all day, but it's definitely something you can kind of help with. And if you feel like, you know what, I'm not really sure how often we should be doing this. I don't want it to be doctor's opinion. I want some sort of evidence-based something for our x-rays. The ADA actually published a chart. It's actually based on caries risk. And so you guys might, if you don't have a caries risk protocol in your office, you might have to implement that as well. But I think with that one, it definitely gives you all of your x-ray frequencies for the different types of patients that you have. And honestly, sometimes you need to take x-rays every 3 months for a couple of months or for a couple of cycles until that patient's getting healthier according to their caries risk. What's not on that chart, though, is the perio implications, the implant implications, the broken tooth implications, and all these other types of things that people come in with. You'll need to add that to your comprehensive radiograph protocol. All right, and the last thing that I have on here is the perio chart. Perio chart needs to be reviewed, of course. I mean, so often. It's not only looked at ahead of time in this chart review, it's looked at during the appointment, it's looked at with the patient in the patient education side. The perio chart, and radiographs too, in kind of that same instance, but the perio chart is really kind of our guiding force here. I recommend going back and reviewing not just the last one that happened, but the last few of them. I think it's really important to see patterns and see, if you're the last person to see that patient, maybe you could probably go back a couple of entries because you are consistent in how you do your perio charting. But if you're not the last person, you probably need to go further back and you're looking for pocketing, bleeding sites, recession, furcation, the whole gamut. And you want to look at the changes along the way. So if, 4 entries ago, they were kind of an unhealthy state, but they're slowly starting to get better, then you'll know how to treat that patient to continue that health. If they're not getting better, then you're like, look, we need some interventions here that aren't currently prescribed. We need a periodontist to take a look at this. We need, perioprotect trays. We need whatever it is that we're going to use for our patient's perio health and get them where they need to be. More than likely, you're going to have several chart entries where it's just stability. And that always makes it a lot quicker. So if you're looking at, my experience would be, if I had a day of 8 patients, we'll say, probably 2 of them are going to be a little bit harder kind of to decipher. The rest of them, if they've been on perio maintenance protocol and prophy protocol for a long time, they're going to be pretty healthy and pretty stable for the most part. And I think it's worth repeating. If you're seeing a patient for the first time, either they're a new patient or there's a scenario where kind of they switched hygienist in between, or the other hygienist was too busy and you're kind of helping out or whatever. Like, I'm not really sure what happens, but if you're seeing that patient for the first time, you're going to want to do probably kind of a more extensive review of that chart. And it's not because like the other hygienist is bad or different. I think we all just have a little bit of variance in how we perio chart. I've had doctors, come behind me and look at my perio charts, and, we're off just a little bit sometimes. And, it's usually within a millimeter or two. It's not that thing significant. It's never usually with those scenarios where it's like, oh my gosh, we have, I missed a 12 millimeter pocket. Like that doesn't generally happen. But it's not just doctors. I think we've all temped in offices, or not all of us, but a lot of us have temped in offices. And, for something that I did for so many years, probably 10 years, I was taking on extra shifts most weekends and going into other offices and working with patients that had seen probably no less than 100 other hygienists at some point, right? Probably somewhere around like, I've followed probably maybe 100 or so hygienists and done their perio charts. Your fellow hygienists aren't bad people. We're all just a little bit different. And so you can't game plan your day when you're doing your chart review around someone else's work. That's just going to lead to headaches and messes and all sorts of other things. And I think that when you're reviewing the charts, again, whether it's the night before or whether it's the morning of, there are so many items that need to be reviewed. But I think if you're able to do the few things that we talked about today, it's going to help you keep your appointments on track. You'll be more comprehensive with your treatment, and you'll be able to relax a little bit knowing that you are prepared. I mentioned earlier, for me, if I have a day of 8 patients, it's probably going to be less than 10 minutes to review all of the charts when we get that kind of practice in. And again, I do think that it's super important that we take something like this seriously. It's going to help us in the defense of our profession. It's going to help us show value to our offices, and it'll help us gain respect with our dentists and our dental teams. I hope this is helpful. Thanks again for listening, and we'll see you all next week.
Yeah, this is a tale, oh yeah, a tale of 2 hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of 2 hygienists.